Thanks for visiting my channel. Today I'll be talking about angioedema. But if you haven't subscribed to my channel, please kindly do. And if you have subscribed, thank you so much. Thank you for visiting again. Let's get the details as per angioedema. Briefly, the outline will include introduction and definition, causes and types of angioedema. Specifically, I'll be diving into bradykinin-induced angioedema. There, we will all go through the pathophysiology, the diagnosis, differential diagnosis, signs and symptoms, the treatment, prophylaxis, short-term and long-term, and follow-up. Introduction. My focus today is essentially on angioedema without urticaria. And that will mean bradykinin-induced angioedema or non-mast cell mediated angioedema or non-histaminergic angioedema. What is angioedema? It is a regionalized or non-generalized fluid extravasation into the interstitial tissues that is limited to the subcutaneous or submucosal and resolves gradually over 72 to 96 hours. Remember, edema generally from heart failure, from renal failure, from hypoproteinemia, will not be limited to just one part of the body, but lymphatic obstruction may be. We'll go into differential diagnosis also. C1-INH is C1 esterase inhibitor caused by mutations in C1-INH gene. Allergy. Are we dealing with allergy when we see angioedema? Well, it's possible there is angioedema with allergy, with anaphylaxis, but it might look like allergic reaction. In bradykinin-induced angioedema, the cause or causes will not be the same, and there will be no urticaria, and it will be non-pruritic. Now, what are the possible causes of angioedema generally? Today, this representation will be focused on bradykinin-induced or non-mast cell mediated or non-histaminergic angioedema. But sometimes it could be from mast cell mediated cause, that is mast cell mediated angioedema, by IgE or direct release from the mast cell or metabolism of arachidonic acid. And it might be idiopathic histaminergic angioedema or idiopathic non-histaminergic angioedema. Angioedema and clinical features. It may be associated with urticaria, particularly if it is histaminergic, as found in allergic reactions and anaphylactic reactions. That is what majority of the people will be familiar with, right? It will not have urticaria if it is bradykinin-induced angioedema. We'll know more about that today. And that will be what will lead us to hereditary angioedema and acquired angioedema. Hereditary angioedema will have positive family history, but the fact that there is no positive family history doesn't rule the probability of bradykinin-induced hereditary angioedema. No, because there might be new mutation in that patient presenting today, and that will be the case in about 25% of bradykinin-induced or hereditary angioedema. Bradykinin-induced angioedema without urticaria may be acquired, So it might be non-hereditary, yet it is bradykinin-induced. So how about that? Either because some cancers are growing right now, particularly hematological related, or the individual is dealing with autoimmune disorders, and there will be negative family history here when it is acquired, and the presentation will be different. For example, in hereditary angioedema, the presentation will be in early part of life, but in acquired, it will be late in life. Probably the autoimmune development will be at later ages, or the cancer onset is not in pediatric age group. So many factors. We will note in details in a bit. Now, angioedema clinical features will essentially be that it will be asymmetric. Unlike renal failure, edema, hypoproteinemia, heart failure, and this time, like lymphatic obstruction, this will be asymmetric in hereditary angioedema. It will be acute in onset. It's going to be from minutes to hours, unlike in renal failure or heart failure or hypoproteinemia. This will be within minutes to hours. It will resolve gradually within 72 to 96 hours. So many textbooks will put it as 2 to 3 days, some will say 3 to 4 days. It's going to have predilection to facial region, mostly the eyes, the eyelids, the lips, the cheeks, the tongue, the neck, affecting the laryngeal region, the throat, the abdomen, and it can affect any parts of the body anyways, but more head and neck region, and of course the abdomen. Can occur anywhere in the body, but not necessarily the gravitational dependent areas like buttocks or pedal regions. For example, in people with renal pathology now having an asaka, and then one part of the body is the part that is resting on the bed, so edema tend to gravitate towards that side, right? That is not the case here. No. It may be histaminergic angioedema, often from allergic reaction to certain foods or allergens. Okay? But that is not what I'm going to discuss today. I will be dealing with the non-histaminergic angioedema, that is bradykinin-induced angioedema. There may be pain or warmth in the affected area. Major cause of death in bradykinin-induced angioedema is asphyxiation from laryngeal edema, and that is as a result of subsequent upper airway obstruction. Because in the histaminergic angioedema with allergic reaction with anaphylaxis, you are going to have bronchospasm, you will have hypotension, you have anaphylactic shock. Then you'll be looking for corticosteroids, your epinephrine, your bronchodilator, your cimetidine, that is H2 blocker, just vasopressor, everything to shoot the BP up, to relieve the allergic reaction going on, to reduce secretion. That is different here. When we get to treatment, we'll understand better. Now, types. If urticaria is present, it could be urticaria or angioedema syndrome. Could also be hypersensitivity reactions, like to penicillin and so on. Now, if there is no urticaria, that is where we're going. There's a patient before us, swollen lips, swollen puffy face, neck, hoarse voice, the back of the hand is swollen, and some pain, cramps in the abdomen. with some diarrhea, nausea, and vomiting. We're thinking of allergy, right? We're thinking of anaphylaxis, right? But there is no bronchospasm. No. So there's no urticaria. And then wondering what is happening. Don't wonder. This is what is happening. That means it is bradykinin-induced. Bradykinin-induced angioedema. There will be no urticaria. That's the first clue. And with that, the thinking has changed. No, 180 degree. The thinking has changed as per the intervention right now to save that life. We have to do one thing first. If this patient is on certain medications like angiotensin converting enzyme beta, ramipril, captopril, elanapril, and so on, stop it. Any non-steroidal anti-inflammatory medication, stop it. Now, bradykinin-induced angioedema. We are getting home. This could be hereditary angioedema types 1 or 2 and 3. As a matter of fact, until the last decade, in 2 decades ago, they have only hereditary angioedema types 1 and 2. There was no type 3. You will understand why in a bit. It could be acquired angioedema and it could be idiopathic. Now, Patho. How did we get here? Hereditary angioedema and acquired angioedema are both caused by C1 inhibitor deficiency or malfunctioning, meaning it is either C1 inhibitor level is low or it is not functioning properly, and it can be both deficiencies. Okay. Complement 1 inhibitor is a protein involved in the regulation of the classical and lectin complement pathways in kinin, clotting, and fibrinolytic pathways of the immune system. Attenuated androgens can increase C1 inhibitor level. This will be helpful when it comes to prophylaxis, right? That is the role that will be useful as a prophylactic agent. We will go through the list of agents for prophylaxis in a bit. Low level of C1 inhibitor or its dysfunction will negatively affect the complement activation and consequently increase the level of bradykinin. Okay, that is the poster. Let me repeat here. When C1 inhibitor level is low or is not functioning normally, then there will be negative effect, on complement activation. Therefore, there will be increased level of bradykinin. Let me get to the next page, it will be clearer. Bradykinin production involves the activated kallikrein, but C1 esterase inhibitor will inhibit the activated kallikrein. Okay, now the low level or dysfunctional C1 inhibitors will lead to more production of bradykinin, while that the effect of the C1 esterase inhibitor to inhibit activated kallikrein is lost. So there will be more bradykinin production. Hence the term bradykinin-induced angioedema. I think that is clear enough. That is how we got into this trouble. And that is why you will not see urticaria, because the problem is that something that is checkmating the production of bradykinin, that is C1 esterase inhibitor, is no longer inhibiting anything. So activated kallikrein is just going across the body and producing bradykinin unchecked. Now, the complements. We will be making use of the value of C4. If C4 is normal, we have to repeat the test during acute attack of the angioedema. We will also check for C1 esterase inhibitor level. The journey has not ended yet. We'll proceed to check for C1 esterase inhibitor function. And it will be appropriate to check for C1q level. We may also check for C2 level as well. Now, hereditary angioedema. Hereditary angioedema is believed to be due to abnormal C1 esterase inhibitor. Either the level is low or the function is abnormal. But is that all? I want someone to give me the answer somewhere. No, that's not the end of it. It can still have normal level of C1 inhibitor. Yes. Some of the olden day textbooks will limit hereditary angioedema to C1 esterase inhibitor low level or abnormal function with C4 low level and normal level of CQ1. But today, in the last 2 decades, it's clearer that we can still have hereditary angioedema without any problem with C1 inhibitor, and that will be in type 3 of hereditary angioedema. Don't worry, in a bit, you'll get that. Still on hereditary angioedema, if C4 level is normal and C1 inhibitor level and function are both normal and accurate, then we will wait a bit, provided that the patient is okay, right? We'll wait for another phase of attack and we will recheck both the level of C4 and C1 esterase inhibitor, including the level of the C1 esterase and the function. If by this time again, C4 and C1 esterase inhibitor level and function are all normal, then it is not hereditary angioedema types 1 and 2, but it may be type 3. Olden day textbooks will just tell you it is no longer hereditary angioedema, but that has changed in recent years. Medicine is not static, it's dynamic. So when C4 is normal, C1 esterase inhibitor level is normal, C1 esterase inhibitor function is normal, don't rule out hereditary angioedema yet. It might be hereditary angioedema type 3, or it could be medication-induced. So, is this patient having diabetes and being placed on Ramipri, or hypertensive and is being placed on angiotensin-converting enzyme inhibitor? Find out. Still on hereditary angioedema, the inheritance is AG. I'm not saying alternative diagnosis, I meant autosomal dominant. That means all what an individual needs is to inherit just one gene from either of the parent, and the disease will just manifest. It's not autosomal recessive when you need both parents to contribute. Just one person is enough to supply. We have 3 types here. In the olden days, there are just 2 types, but there are just 2 main ones. So we can't blame the whole textbooks that limited it to just two, right? Why is it that there are just two main ones? This may change, might be in the generation of other medical doctors that are in elementary school right now. Might be it will change from just two main ones to main three types. Okay, why just two main ones? Type 1 hereditary angioedema is close to 80% of all hereditary angioedema. And it is characterized by C1 esterase inhibitor deficiency. Okay. Why type 2 hereditary angioedema is close to 20% of all hereditary angioedema. So you could see only two main ones. Where is type 3 here? Not so common. Probably the record is not yet out. By the time the data is out, this percentage will change, I bet. Here in type 2, the problem is C1 esterase inhibitor abnormal function. Abnormal function. Now type 3. I'm interested in this, right? Okay. It's also known as hereditary angioedema with normal C1 inhibitor level and function. There could be defects in several genes here. So it is hereditary, right? For example, factor 12 is also affected, plasminogen is also affected. But for now, it is a good news to hear that it is very rare. Probably rare because not enough data as of today, 2021, right? With normal C1 inhibitor level, also normal C1 inhibitor function. The prevalency is unknown because the record is not yet out. It's found mainly in women. That one is correct. That is not to say it's not found in men, but majority of patients with type 3 will be women. And it is related to estrogen. Some would define it as estrogen dependent. So women on combined oral contraceptives, containing estrogen or hormone replacement therapy, now having angioedema and say, oh, it's not common in my family, they don't have it there. You are dealing with type 3. Acquired angioedema. This is very rare. It has two forms. It has acquired angioedema type 1. These ones are associated with malignancy of B-cell lineage or breast cancer and so on. There's acquired angioedema type 2. These ones are associated with autoimmune disorders with C1 esterase inhibitor autoantibodies. In a bit, we'll understand why it is so. Now, still on acquired angioedema, from cancers and autoimmune disorders, like I've just given an example on type 1 and type 2 acquired angioedema, right? C4 is consumed, so C4 level will be low. And with that, in neoplastic disorders like B-cell lymphoma or immune complex disorders, C4 will be consumed. Still on acquired angioedema, antibody against C1 esterase inhibitor could have been produced as a monoclonal gammopathy or autoimmune diseases like systemic lupus erythematosus, rheumatoid arthritis, Hashimoto's thyroiditis, and so on. But there's one thing that will make it classically different from hereditary angioedema. It's going to present later in life than hereditary angioedema that the onset will be in childhood or adolescence. Why that? Likely because most of the cancers and autoimmune diseases will be found at that age. We have to be specific. So we have to determine if we are dealing with hereditary angioedema type 1, type 2, type 3, or acquired angioedema or idiopathic angioedema. Okay, in type 1 hereditary angioedema, this is about 80% of all hereditary angioedema cases. So it is fair to say that if you don't know the type of angioedema and it is hereditary, if you call it type 1, you are not too much in the bush, but you might need to come back to the road anyway, so don't get lost. This is characterized by C1 inhibitor deficiency, and the inheritance is autosomal dominant. In type 1, when you have done your complement testing and then your laboratory investigations, you are likely going to find the following results. C4 will be low or reduced. C1 esterase inhibitor level is low or reduced. C1 esterase inhibitor function is reduced or there is dysfunction. And C1q level will be normal. Also, in type 1 hereditary angioedema, there will be no clinical suspicion of acquired angioedema, but there will be positive family history. And it will present at early part of life, early age of onset. When you find all this, then target. The diagnosis is type 1 hereditary angioedema. In type 2, that is type 2 hereditary angioedema, this will be close to 20% of all hereditary angioedema, with C1 esterase inhibitor abnormal function. The inheritance is the same, autosomal dominant. Okay. When you have done your complement studies and everything, then you are going to likely come out with the following results. C4 level will be low. C1 esterase inhibitor level is normal or raised in type 2, while C1 inhibitor function is abnormal. So they have enough C1 esterase inhibitor, but it's not functioning well in type 2. C1q level will be normal. As a matter of fact, C1q level will be normal in all hereditary angioedema, but it will be low in acquired angioedema. In type 2, there will be positive family history and it will present early in life like type 1, but there will be no clinical suspicion of acquired angioedema. Then, if you have all this, target. The diagnosis is hereditary angioedema with C1 esterase inhibitor dysfunction, and then you are dealing with type 2 of hereditary angioedema. Now, type 3. I'm interested again. Type 3 hereditary angioedema. Someone is saying, so you've not been interested in the rest? No, that's not it. But something has changed in recent years in medicine when it comes to this, right? It's also known as hereditary angioedema with normal C1 inhibitor. There will be defects in several genes affecting factor 12 and plasminogen. It's very rare, good news, with normal C1 inhibitor level, also normal C1 inhibitor function. The prevalency is unknown because we've just gotten to know about this diagnosis, right? Don't worry, data will soon surface. In the next 10, 20 years, the story will change. Medicine is not static, it's dynamic. It's found mainly in women. That is not to say it's not found in men, but more in women. And it is related to estrogen, so it's estrogen dependent. Combined oral contraceptives, pregnancy, and so on. Okay, when you've done your studies when it comes to type 3 and you find the following results, then you can make that diagnosis: normal C4 level, normal C1 level, normal C1 function, normal CQ level. No medication is involved. And someone will say, then why do you still call that a problem? Everything is normal, but the patient is suffering. Okay, acquired angioedema is already ruled out. There's positive family history, but not in all cases. Not responding to antihistamine or corticosteroids like histaminergic or mast cell mediated angioedema. It's going to fail. You have given everything you are supposed to give because the thing that is allergic reaction, no. Could be triggered by combined oral contraceptive, I've mentioned that, hormone replacement therapy, I've mentioned that, and pregnancy. Females. Ask me who will be pregnant before, if not females. With estrogen effects, of course, we know that. Then you can be comfortable enough to target and make the diagnosis as type 3 hereditary angioedema. Acquired angioedema. Very rare. No associated with malignancy of B-cell lineage breast cancer, autoimmune disorder, C1 inhibitor, autoantibodies will be present because we're dealing with autoimmune from cancer or autoimmune diseases. So someone is having systemic lupus erythematosus, rheumatoid arthritis, type 1, diabetes mellitus, and hypothyroidism due to Hashimoto thyroiditis and so on. And now having edema without taking ACEI inhibitors, without taking NSAIDS, without taking DPP4 inhibitors, then be thinking acquired angioedema. Here, there be antibody against C1 inhibitor, and that could have been produced by monoclonal gammopathy or autoimmune diseases in origin like SLE, Hashimoto's, like I've said. One thing will give you another clue here. They present late in life, unlike hereditary angioedema that will present at early part of life. So you've done your complement studies and some other investigations. You're likely going to find these results. C4 will be low because it's being mopped up by the neoplasm, right? C1 inhibitor level will drop, and C1 inhibitor function will be low or there will be dysfunction. And C1q level will be low. Remember, it will be normal in hereditary angioedema types 1, 2, and 3. In acquired, C1q level will be low. There will be no positive family history here, negative family history. C1q level is low. I decided to bring this out as classical differences between hereditary angioedema and acquired. So negative family history, CQ level is low, late age of onset. If it is hereditary, the positive family history, CQ1 level will be normal and early age of onset. So we have opposite here. Then you can conveniently label this as acquired angioedema. Idiopathic angioedema. It is idiopathic in medicine. There's somewhere to hide when we've tried everything and we don't know what is happening. So it is idiopathic after no specific cause is determined. Right? We are still battling with recurrent and sudden episodes, angioedema without urticaria, and we've excluded allergic reactions, drug reactions, and no defect in the complement pathways. So when we go to lab, we likely come down with normal C4, normal C1 inhibitor, normal C1 inhibitor function, level of function all will be normal. Now, idiopathic angioedema will become the order when there's negative family history, but there may be medications involved like ACEI and NSAIDS, may be triggered by allergy to milk or just any allergen or stress or illness or autoimmune, may be developed within 1 week of starting the medication or after years of use. And there's no suspicion of acquired angioedema. The diagnosis will be idiopathic angioedema when the cause is difficult to determine. Idiopathic means unknown. Okay, what could be the triggers of hereditary and acquired angioedema? Could occur spontaneously, could be as a result of pregnancy, estrogen, particularly in type 3, certain foods, cold exposure. So what will happen to those living in temperate regions in winter? I feel for them, right? Viral illnesses, emotional stress. So if you have been diagnosed with angioedema, hereditary angioedema, you better make life easy for yourself. Get out of the stress. Tongue piercing. Did you hear that? Trauma, surgery, dental procedures, and sometimes we don't know what could trigger it. Signs and symptoms. For angioedema due to allergic or anaphylactic reactions, signs and symptoms, please kindly check my channel right here for full presentations on them. My focus today will be on angioedema without urticaria, otherwise known as Bradykinin-induced angioedema, and I'll be going through the signs and symptoms of that alone. Okay, there'll be swelling. The swelling here will be asymmetric, painful, non-pitting, and airways could be involved with life-threatening breathing and swallowing difficulty. But note this, there is no bronchospasm. The swellings can occur at the face, the lips, the tongue, the back of the hands, the feet, genitalia, but can occur in any part. However, not at gravitational dependent parts. There may be hoarseness of voice when the laryngeal region is involved, or there is laryngeal swelling. There may be throat tightness. Laryngeal swelling will be the leading cause of death in these patients. They will have stridor, breathing difficulty, and swallowing difficulty. Intestine could be involved with intestinal obstruction. Swelling of the membrane lining the entire gastrointestinal tract is possible from mouth to the intestine and even the lining of the airways. So when the abdomen is involved, there will be cramps, abdominal discomfort, nausea, vomiting, and there may be diarrhea as well. Swelling will gradually resolve in 1 to 3 days post-onset, but it may reoccur. Some textbooks will put it as 4 days, 2 to 4 days. Some say 1 to 3. Just know that this is not related to heart failure. It's not related to renal failure that will not regress on its own. This will regress on its own, gradually, within few days. Diagnosis. Hereditary angioedema and acquired angioedema could be fatal, could kill, and is mainly or majorly diagnosed clinically. Conventional treatment for allergy and anaphylaxis will not work here. It will fail. So your EpiPen or epinephrine will help in reducing the swelling and helping in intubation, but it's not going to handle everything about bradykinin-induced angioedema. I'll tell you what will help in a bit. So, because it could kill, accurate diagnosis is the key to life-saving interventions. There is a definitive treatment. We'll get into that in a bit. But that will be a mirage without correct diagnosis, because once we swerve to the other side thinking this is allergic in origin, this is an anaphylactic reaction, and then we jab the patient with everything that will not help, and the patient will be dead. Now, the diagnosis fully. We have to take a thorough history. And the history will start by asking, is this the first time? And if it's not, when was the first time? So the onset at what age? If this patient, will tell us, okay, this happened, the first time ever in life at so age, and we trace that to be childhood or adolescency, or the patient is actually an adolescent, or the patient is a child, then there's a clue. We might be dealing with hereditary angioedema. Why that? Because acquired angioedema will present late. Okay? Then we move on. Any positive family history of this? If the answer is yes, okay, it might be hereditary angioedema types 1, 2, or 3. But we will not lose sight of the fact that there may be new mutation in about 25% of cases, meaning there may be no family history today, and this patient might be the first person to have it in that family. It is still genetic in origin, but there's no record in that family. So new mutation will be the order of the day in about 25% of hereditary angioedema. Okay, then we'll go further down to medications. Are you on, maybe ACEI inhibitors like Ramipri, in people with diabetes mellitus? And though it's not because they have high blood pressure, they are on it so as to give them cardiorenal protection, okay? And then captopril, elanapri, and so on if there's hypertension, any non-steroidal anti-inflammatory drugs, any estrogen, particularly in type 3 hereditary angioedema, DPP4 inhibitors, calcium channel blockers, herbs, and so on. So the history will cover that. And of course, the history will cover autoimmune conditions because acquired will have a link to autoimmune sometimes or cancer. So any ongoing infection, particularly in children, we want to know more importantly, viral infections. And of course, malignancy, going on somewhere. Okay, we are done with the history, right? Then physical examination, head to toe. I want to check where those swellings are. I will check, okay? Then level of consciousness, any obvious distress in this patient. Because when there's massive laryngeal swelling with hoarseness of voice, breathing difficulty, swallowing difficulty, that patient will be sweating and breathing with much energy, okay? We check the BP, the respiratory rate, the temperature, let me just say vital signs. And swellings to be checked everywhere, the face, the lips, the pharynx, the larynx, the neck. Full abdominal examination, full respiratory examination, check the skin everywhere, and of course, cardiovascular system examination. Okay, we now head to the lab. We want to have complement studies. What is the value of C4? How about C1 estrogen inhibitor level? And of course, the function, C1q level and C2 level. Okay, we are still working on our diagnosis, right? We'll go to the lab for complete blood count. Because differential white blood cell can give us clue to infection, right? Pharyngeal culture or blood culture, acute phase reactants like C-reactive protein that will be pointing to infection, cancer, inflammation, and also angiotensin converting enzyme induced angioedema. In the phase of ACEI induced angioedema, there will be high level of C-reactive protein. The erythrocyte sedimentation rate will be pointing to infection if it's very high, also inflammation, cancer, and autoimmune diseases. These two, the acute phase reactants, that is C-reactive protein and ESR, cannot tell us the specific type of condition going on, causing the inflammation, or giving us clue that there is ACEI inhibitor or there's autoimmune somewhere or there's cancer somewhere. But it will let us know that things are not right. What is happening to the liver? Liver function test, renal function test, thyroid function test, antinuclear antibody. Why are we doing the antinuclear antibody? We've just talked about autoimmune, right? Right? Okay, particularly in acquired. Then we have analysis done. Absent, we want to see what is happening in the abdomen. When the woman is complaining about abdominal cramps, nausea, and vomiting, a woman of childbearing age, have you done beta chronic gonadotropin? Then what else is happening in the abdomen? Okay, CT of the abdomen and the chest to see more, X-ray of the sinuses, because everywhere is swollen and along the head and neck region, right? Then let's do something. If this patient is on certain medication that we are suspecting could be responsible for this angioedema, let us have medication withdrawal challenge. Yeah, stop that medication for a while and let's see if this swelling will still persist. Now, the differential diagnosis. Is this renal failure? That is generalized edema, known as an ACEI? Want to know? Could this be cellulitis? Because it might be limited to just one part of the body, and the features will be close to that. Is this erysipelas? Is this facial lymphedema? Because it will be non-pitting also. Could it be contact dermatitis? Mind battling with autoimmune conditions, particularly in acquired angioedema, right? Might be hypothyroidism. Now, probably facing hypothyroidism, enlarged tongue and hypothyroidism. It might not be, it might be angioedema, parasitic infections, eyelid edema, because the eyelids are swollen, superior vena cava syndrome. Check my channel for that. I have a separate full presentation on that. Could be heart failure. Could be laryngeal foreign body, because the fact that that part of the body is swollen and is compressing the trachea and esophagus doesn't mean it's angioedema alone. It could be foreign body present there. Might be peritonsillar abscess, could be tonsillitis, could be vasculitis. When the abdominal problem becomes the main focus, might be mesenteric infarction, might be inflammatory bowel disease. Okay, now the treatment. The treatment will either be in emergency room if we are dealing with acute cases, or short-term prophylaxis, or long-term prophylaxis and follow-up. Acute cases in emergency room will be the choice if we are dealing with severe angioedema that is blocking the larynx, blocking the airway, or we have big tongue that is now obstructing the airway. The first choice of medication to use here is C1 inhibitor that is purified preparation. So, purified preparation of C1 inhibitor is the treatment of choice in severe attacks. Why that? The core of bradykinin-induced angioedema, that could be hereditary angioedema, is because we are likely dealing with C1 inhibitor low level or C1 inhibitor dysfunction. So it is fair to say when we are able to replace C1 inhibitor, we are likely going to get out of the wood. So the example here of purified preparation of C1 inhibitor will be Cinryze, Verinet, or Ruconest. Now, in emergency room, first thing first, check the airway, any foreign body, any secretion, suction as is appropriate. How about the breathing? Any breathing difficulty? What is the respiratory rate? nasal flaring, accessory muscles being used, the chest and abdomen moving together, we check all that. Circulatory system, what is the BP, what's the heart sounds, we check all that. And the next thing is grab our epinephrine, okay, and jab the patient, preparing for intubation. And of course, we continue to monitor the vital signs because it's of no use if the patient is dead and then you are still intubating. Prepare for tracheotomy because you may have difficult intubation. Remember, laryngeal swell, obstructing, the passage right there. Get IV fluid, okay? And of course, purify plasma-derived human C1 inhibitor. Still in the emergency room, you can make use of a kallikrein. That is a reversible inhibitor of kallikrein. Example is the trade name here. And icatibant, and for example, the trade name is there, but this is not good for ACEI inhibitor-induced angioedema. It's not. So if the cause of this angioedema is ACEI inhibitor like ramipril, captopril, and enalapril, don't use icatibant. Landelumab is for prophylaxis, not for acute phase. It is a monoclonal antibody to bind plasma kallikrein and block its activity. Okay, fresh frozen plasma could actually make angioedema worse. So we may not go for that unless we don't have any other useful medication to help around. In Europe, you can make use of tranexamic acid and conestat alpha. Conestat alpha is a recombinant C1 esterase inhibitor. That's pretty good, right? In India, you can use epsilon aminocaproic acid, and some give this at 12 to 18 grams daily. You may decide to give analgesic to handle the associated pain, but I believe if the swelling has subsided, the pain will also disappear with it. You can use antiemetics if the vomiting is becoming burdensome to handle the abdominal involvement with nausea and vomit. Okay, short-term prophylaxis. We want to help these people, right? We don't want them to come down with acute attack and die. Okay, the best thing to do is to give them C1 inhibitor replacement. And you can give that at an hour before the procedure of head and neck region. That is dental procedure or any procedure involving the airway. If you don't have that, C1 inhibitor purify preparation, then you can give danazol. But remember, you might be battling with acne, huge hair growth, and male voice or masculinization. Remember, you are dealing with hereditary angioedema that is likely going to present in childhood or adolescence. And this is a girl, now maybe 14, 15, 16 years old, and you give danazol, and suddenly the voice changes to that of a guy. I don't think she will come back thanking us for anything. Sanozolol is no longer used in many countries, but since my presentation will go anywhere, I need to mention that some countries are using it. Well, to those who are not, kudos to those who are still using it. Just be careful with it. And when they give it 5 days before the procedure and 2 days post procedure. but the best option here is C1 inhibitor replacement. For long-term prophylaxis, attenuated androgens like stanozolol 2 mg per oral TID, danazole 200 mg per oral TID, but let the patient know the side effects or adverse reactions of it, then gain consent, then, well, discuss with your team anyways, but the best option here will remain C1 inhibitors. That is the most effective, in acquired angioedema, but it is very expensive. Danazole is expected to stimulate the body to produce more C1 inhibitors, but it is less effective for acquired angioedema. In acquired angioedema, you have to go for the treatment of the associated cancer. Remember, acquired angioedema will either be as a result of malignancy or autoimmune condition. So, get hold of the malignancy or the autoimmune condition, and you can be sure you are helping the patient out of acquired angioedema. In type 3 of hereditary angioedema, please, the advice is keep estrogen off the table. So, this woman is now down with type 3 hereditary angioedema. Okay, madam, I'm not going to give you combined oral contraceptives. Anything containing estrogen will be off the table for you. You can always use other agents, okay? Now, if we are faced with refractory type of case, then we have a calantide to make use of. FFP, that is fresh frozen plasma, particularly if it is related to angiotensin converting enzyme induced angioedema. Icatibant could be helpful. Rituximab or dapsone. Well, have that robust conversation with your specialist around. I mean, someone who specializes in angioedema or in allergy or pharmacology or your pharmacist. Okay, this presentation will be incomplete without praising everyone who will look at angioedema and think that, oh, this is an allergic reaction or it is anaphylaxis somewhere, and treat as such. But if we do not take appropriate history and think or do appropriate investigations and know exactly that this is bradykinin-induced angioedema, then it might be activity in futility when we treat bradykinin-induced angioedema with corticosteroids, antihistamines, H2 blockers, glucagon, and vasopressors. All these are meant to handle allergic reactions and anaphylaxis, and I appreciate that. But you can see going through the treatment that if we miss out, C1 inhibitor replacement, we may not get out of the wood. And finally, follow up. Appropriate referral should be made to the specialist or family physician to follow up and Hereditary Angioedema Association. Well, thanks for listening to this lengthy presentation. I have taken you through bradykinin-induced angioedema. We've gone through hereditary angioedema, and in bradykinin-induced angioedema, I have made it clear that this will be angioedema without urticaria. And that is what is going to, first of all, give us the clue that we are not dealing with allergic reactions. We are not dealing with anaphylaxis. So this is not mast cell mediated. It is not histaminergic. So it is bradykinin-induced. The problem here is C1 inhibitor problem, but sometimes it could be normal in type 3 hereditary angioedema. We've gone through the acquired angioedema also, where the problem is not limited to family issues, but it is as a result of cancer somewhere or autoimmune diseases somewhere. We've gone through the treatment that has brought it out that the conventional treatment for anaphylaxis or allergic reaction might not suffice here. So we've gone through the list of medications that are specific and helpful in preventing death, including short-term and long-term prophylaxis in patients with bradykinin-induced angioedema. Thanks for listening. Please share this with everyone. My heart goes out to everyone affected, and I appreciate. Please remember to subscribe to my channel also. Thank you.